Welcome to another episode of the Doctors and Dollars podcast, where we discuss health insights and wealth secrets. I'm your host, Nate Crannell, joined today by Dr. Abraham Sheffield. Abe grew up in the Midwest and then completed his undergrad at BYU in Utah. After a 2-year mission trip in Japan, he decided to dive back into his education and get his medical degree in otolaryngology and a PhD in genetics at the University of Iowa. Married to Erin, an oral surgeon, they now live and work in Quincy, Illinois at a multi-specialty medical group. When not doing all things ear, nose, and throat, Abe loves to spend time with his wife and 3 young children playing basketball, cycling, playing saxophone, and baking birthday cakes. Welcome to the show, Dr. Sheffield. How are you? What's going well today?
I'm doing well. Thanks for having me, Nate. It's good to be here.
Awesome. What's going well?
Yeah, so I just I'm in Austin, Texas right now for a little a
Nice.
men's group conference that I'm in. It's the group is called Front Row Dads, and it's guys who business-minded people who want to put their family first, and just getting together with some guys and talking about how to be better dads and husbands.
I mean, you can't argue with that. I mean, think of a better group. I mean, you could have said we're coming down for a doctor's group or we're going to have hors d'oeuvres and be wined and dined. No, you're talking about being a fantastic dad. That is awesome.
Yeah, no, it's been good. Family is definitely a priority for me, and the medical careers and any career really often kind of pulls you away. There's always more to do at work, and so I think if you're not intentional about what your priorities are, it's easy to get off track.
For sure. I mean, I thought my priorities were there, but going to a conference would be pretty cool. So I might have to call you here in a few days and say, hey, what's the secret sauce?
Yeah, I'll let you know how it is.
Nice. Well, I also need the secret sauce on how to pronounce your medical degree. I think I butchered it in there in the bio.
No, you did great. My wife tells me it's the hardest word to pronounce in the English language.
Has to be.
I don't know where she read that, but it's oto, which means ear, larynx, which means throat, and then ology, the study of it. But so otolaryngology, if you want to make it even longer, you can stick a rhino in there, which means nose. So otorhinolaryngology, ears, nose, throat. A lot of people just say ENT, which is fine with me.
Yeah, I think I said Odo. I can't remember if I said Odo or Otto. We'll go play it back and listen again. But yeah, when I was doing my research on you before the show, I saw that word and I'm like, man, I'm gonna have to practice that thing a few times, and I still think I butchered it. But ENT, I think we'll stick with that. Anyone can say ENT.
That sounds good.
Nice. Well, let's dive right into it. The ENT thing, obviously, we'll keep on that trend. I definitely have some questions about that, specifically around tubes, just because I remember being that kid when I was 8 years old in the swimming pool, tubes in his ears, freshly in, had to wear that little headband thing with the little gummy things in my ears so that no water got in there.
Yeah,
traumatizing. But we're not going to start with my childhood trauma. What took you into ENT? And more specifically, like I said in the bio, a PhD in genetics. Those are, to me, those are 2 wildly different things, but you've somehow married them together.
Yeah. So I'm the type of person that I like a lot of different things. And so honestly, it's hard for me to make a decision because I found interesting things in a lot of different fields, a lot of different medical specialties. My dad is a physician. He's a medical geneticist, so maybe that had some influence on the genetics part. So I, being around him, being around his colleagues, I think kind of like a lot of people got my interest going in medicine, and I was probably early in college when I decided to do the pre-med courses and go that track. But then when I got to and then I also realized that I liked research a lot, and I liked learning new things. I worked in a laboratory, science lab in the summer breaks during college, and saw that and saw how much my dad loved a research career. And so that kind of got me interested in the research science side of things. And they have these programs, combined MD, PhD programs, that where you can kind of do both. They're training physician scientists, people who are trained, as physicians to see patients, but also trained as scientists to, to research new things. And so once I heard about that, I got interested in that, and I applied, and they're pretty competitive programs to get into, and I honestly didn't think I stood a great chance to get in, and
Really?
but I got accepted at University of Iowa, and which I grew up in Iowa City, and so that's my parents are there, and a lot of friends there, so that was super great, and I felt like that was the right thing for me to do. And in these programs, you do 4 years, or you do your first 2 years of medical school, and then you take a break from medical school and you go into the PhD program. And the most important, in my opinion, the most important thing in picking your PhD program is picking your mentor, the person who's the scientist whose lab you're going to work in. And at University of Iowa, there's a lot of great scientists, a lot of great mentors. I was drawn to the lab of Dr. Richard Smith, he's a pediatric ears, nose, throat doctor, and also runs a genetics lab that studies hearing loss and the kind of the genetics of deafness and hearing loss. And I had a really good experience rotating in his lab, and I decided that he would be a great mentor, and I'd get to do interesting things there. And so I worked in his lab for my PhD, and got the PhD in genetics, and I was studying gene therapy for hearing loss. And spoiler alert, no, we have not cured hearing loss yet, but I got to learn a whole lot along the way, and do some cool experiments, and meet a lot of great people, and learn a lot of things. And then after you finish your PhD training, you go back into the medical school program, your clinical rotations, and that's when you rotate through the specialties. And I wanted to go into that. I'd had that influence with Dr. Smith and other mentors in the ears, nose, throat department that got me interested in that field. But also I wanted to go into things with an open mind. I wanted to do clinically what I enjoyed the most. And so I went into my rotations with an open mind. I found things I liked about pretty much everything. Like there were certain rotations. I think like radiology, I did not think I'd be a radiologist, even though it's a super awesome career. I just am not that visually oriented, and psychiatry, although I have some of my best stories from medical training from my psychiatry rotation, I knew that probably wasn't going to be the route I chose. I became really interested in anesthesiology and and also dermatology. I particularly like the surgical side of dermatology. It's called Mohs, MOHS surgery, where they're cutting out skin cancer and doing reconstructions. And then I was interested in ears, nose, throat, and I really honestly agonized over which of those I should do, because I could see myself doing any of them, and enjoying it and being good at it. And ultimately, a lot of discussions with a lot of people, thought, prayer, sleepless nights trying to figure out what would be best for my future. And I ultimately landed on ears, nose, throat, otolaryngology. I felt that I knew that if I could stay at University of Iowa to do that, I would get incredible training from fantastic mentors. I already felt like I dedicated 4 or 5 years to that field, and so I felt that made a lot of sense, and I liked the variety. For being a small area of the body that you're focused on, there's a really big variety of of things that you can do. It's a surgical specialty, but there's also a lot of medical management, and you get all ages from babies all the way through elderly people, and I just felt like there was a really nice variety, and it ultimately is what I chose.
Yeah. So it sounds like Dr. Smith was a great mentor for you. You had some great research, some coincidentally also did genetics as well. But did you have a feeling when you went back into clinical rotation that like just knowing your personality and how you interact with so many different things, did it kind of worry you to be like, hey, I have been ENT focused with Dr. Smith for so long. If I go into these rotations, I'm going to be like a cat in a shiny ball. Something's going to catch my attention and draw me away from it. Was that what was causing the sleepless nights?
Yeah, I think the sleepless nights were just these decisions seem very big, right? Like once
Mm-hmm.
you commit to something, uh, like you don't. I mean, some people do go back and do another residency. You can switch, but it's best not to. It's that it's a it's a big process, and one residency is enough for for most of us. And I wanted to do something where that I'd be good at, that I would feeling like I'd be making a contribution, and that I'd enjoy going to work. I had a lot, I had a lot of role models, including Dr. Smith, including my dad, and other physicians who really, are passionate about their jobs. They love what they do, and I wanted to, that's what I wanted for me as well. And so
For
I just
sure.
wanted to, make sure I was picking something good.
Yeah. Take me behind the curtain. And this is something I've never asked a physician before, but I'm going to ask you. Behind the curtain, is it kind of like National Signing Day in college athletics when it comes time to go through your rotations and you have to pick your specialty? Is it like you sit down with a pen and paper and as you're signing it, you're like, this is it. This is where I no turning back now? Or is there always you said some people go back into residency, which sounds awful if you're going to do that for a few years and then you're like, oh, I'm going to redo it all over again. But is it kind of like National Signing Day if you're familiar with that process of you
Yeah,
just sit down and it's like you pen to paper?
yeah, it is. I mean, ultimately there is a point where you can't easily go back. It's the residency, it's a match program. And
Mm-hmm.
so there's a deadline for that. You submit your applications, and and I was actually I was a late enough decider that I actually submitted applications to a couple of different specialties,
Mm-hmm.
because I still had not made a final decision. And ultimately, I knew, by the time it came time to make my list, I needed to have narrowed it down. But that was still months away. And so I initially, because I wasn't sure, I wanted to keep options open, I put in applications for a couple different specialties, and then but ultimately, and then you can interview, the
Mm-hmm.
programs you apply to, some of them will invite you for an interview, and then ultimately there's a time where you have to submit which of the programs that you interviewed at you're gonna put on your list, and which order you're gonna put them in, and
Mm-hmm.
then the programs do the same thing with the medical students that they interview. They put, okay, here's my top choice and second, and down the list, and then it gets stuck into some magic computer algorithm that supposedly matches things up appropriately. And so when you hit that submit button on your rank list, that's kind of the end of it. But before then, it's most of us know before then, and I'd made a choice before then that I was going to do ears, nose, throat, and I had talked to the Dr. Smith and other mentors, and I went and talked to people that I knew, like in the anesthesia department, who had been helping me as well, and told them, hey, your specialty is awesome, but I think I'm gonna, ENT is gonna be best for me. And so those can be challenging conversations to have. If you're telling people no, they can be really great conversations if you're telling people like, yeah, I want to do what you do. But one of the things I learned from that is that at least the mentors that I interacted with, and I think this is true of any good mentor, they want the best for you. And so
Mm-hmm.
even if, and I remember there's one point when I was telling Dr. Smith that, hey, I think I'm maybe interested in something else besides ENT, it's really meaningful to me. He said, I like, that's fine. You'll do great at whatever you want to do. And I think of you like a son, and I want you to be happy, and I'll support you in whatever. And conversations like that are super valuable. And those are the type of mentors it's really important to find.
Yeah, challenging to find. Many people never find it. I think I would equate the same thing. Kind of leaving the corporate America, and then I became a financial advisor, and I had fantastic mentors, at the company I was with. And then even when I decided to leave and branch off and start my own private equity company, again, those same mentors who, had put time and energy into me, still said, "Hey, if this is best for you, spread your wings and fly." And so I think that's always good to have. And with the amount of years that you dedicated to this, I commend you for going to other mentors outside of ENT, because you're right. They could have turned and swayed you again, and
Yeah.
then you're sweating even more bullets. So
Right.
yeah.
Yeah.
The interesting thing to me about you, Abe, then is you went through all this. Oh my gosh, what do I do? I'm going to pick my specialty. Then you get into that residency program. You get through residency, everything's great. You're ready to become a doctor, and then you decide to do a fellowship.
Yeah.
What was it?
Yeah.
Which I gotta imagine is another process that's even higher level than residency. Like, talk me through that
Right.
process.
Right. Yeah. So, yeah, I guess a theme in my life is being a late decider, maybe, and my wife will attest to that as well, since I probably took longer to propose marriage to her than she would have liked, also. But as long as you make the right decision in the end, you're good, I think. So yeah, I was, I'd been through all this. The MD PhD program was 8 years. ENT residency 5 years. So I've been at this, I'd been at this for 13 years, and my
Wow.
wife she was a little bit ahead of me in finishing her training in oral surgery. So she was done. Uh, she, we were ready to kind of, move on with, like, get real jobs, settle somewhere. Uh, and, and, uh, and it was when I, it was the beginning of my last year in my 5th year in ENT residency, and I was doing a pediatric ENT rotation, and each year you rotate through the different kind of subspecialties, and I just that 5th year you're doing a lot in they let you do more complex cases and be doing more stuff, and I realized that there's a lot of stuff in ENT that I liked, but I was just loving the pediatric stuff. I
Mhm.
just like I was it was like my best time in my residency was on this pediatric rotation in my 5th year, and my mentor, I ended up being at University of Iowa, so I got to work with my PhD mentor, Dr. Smith, more, and he and I think he sensed that I was enjoying it a lot, and he said I was good at it, and he and it turned out that they had not matched someone, that, like, the pediatric match had happened, and it was pretty unusual, but they had not filled a spot, and so they had a spot for me, or they had a spot
Nice.
for someone, and so he said, hey, and I'd already, again, these difficult conversations, I'd already told him, and the first time he approached me with it, I said, I said, no, Aaron and I were, we'd already decided to go to Quincy, Illinois, and
Mhm.
uh, and do general ENT,
Yeah. And
uh,
mind you, no kids yet, right?
we had just we had twins that were about 1 year old. So
Okay.
we just had kids. And so we were just like more reasons just to
Okay.
be done. And I said, no, this is not what we're gonna do. And then, like, I remember this so well. I was at Disney, like, we were on, I think there's oh yeah, we were meeting Aaron's sister and her family at Disney World. Our kids were like 11 months old. We knew they weren't going to remember it, but we were going to go down and just,
Mhm.
hang out with family. And the night before, I had another, like, sleepless night, because like, part of me like was really wanting to do this fellowship, but another part was really wanting to not do it and just move on. And it just at some point it just hit me like, hey, you should do this. This is a really good opportunity for you. And I remember calling Dr. Smith like as I'm walking through the main gate at Disney World and being like, hey, is that spot still open or did you fill it already? And because if it's still open, I'd like to do it. And it, you know, I had been, we can talk about this more later if you want, but I'd been exposed to academic medicine my whole life. My dad worked at the University of Iowa, and that's, you know, him and his colleagues, that's what I'd been exposed to. I was on track to, you know, do research and see patients and kind of be an academic doctor. And then ultimately, Aaron and I decided that we are going to be in private practice, and it didn't really make sense to do the fellowship from kind of a career standpoint. It would, you know, just delay things a year. I wasn't gonna, you know, I'd be doing more general ENT anyway, where I ended up. But it gave us an extra year in Iowa City, which is where my parents were. And when you have twins that are like a year old, it's really nice to have parents close by.
For sure.
And so kind of having an extra year of that family support was a definite bonus. Again, I knew I'd get amazing training that second year that would, you know, make me a better surgeon, a better doctor. And I also felt like it would keep my options open a little bit to where if I got into because when you're in training at these universities, you don't get to see, you might do some private practice rotations, but you don't really get to see private practice life really well. And so there was a little bit in the back of my mind, like, hey, what if I don't like being in private practice and I want to go back to the university setting? I felt that having a fellowship would make that easier to get back into. So had some good reasons to do it, and ultimately it felt right, and I'm glad I did it. Honestly, it was my like that year was hard. You work hard. There's a lot of responsibility, but I look back on it as my very best year of training. I grew so much and learned so much that year.
Yeah, that's one of those instances where padding your resume, as you might say, kind of in the corporate world, benefits you just because it gave you more flexibility, more options for the just in case. Like it allowed you to, if you had that fellowship, you could go back to the university setting. Without it, you probably would stay in private practice, or private practice would really be the main option for you. And so a tough year, but obviously that sets you up for it. Hey, now, I mean, you've been in private practice for a few years now. I mean, you could go back to the university setting at some point in the future, and I think that helps. So nice work being mindful of that. As you're raising two young kids, have a wife, there's a lot on your plate. So probably not an easy decision at all.
Right. No, they're tough decisions, but yeah, you do your best at the time.
Yeah. Tell me about those conversations with your dad, because he's been in the university setting, in a research setting, more specifically. What type of guidance did he give you as you were going through residency, you know, well, picking ENT and then going through residency, contemplating, you know, as you're walking through the doors of the Magic Kingdom, trying to decide, you know, if you're going to do this fellowship, what type of advice did you give from your dad, someone who was not in that setting and didn't maybe understand everything that you were trying to decide on?
Right. Yeah, no, I mean, it's really nice having a supportive dad who's kind of, you know, in that same field. He and I are a little bit different in that, you know, he loves research. His career, even so, he has an MD and a PhD also, and he's a pediatrician. Then he did a fellowship in medical genetics, and so he would see genetics patients. But that was a small, and he enjoyed it. He would tell, you know, stories about, you know, things, you know, impacts he's made and interesting patients he'd seen. And you could tell that he really loved the patient interaction and was good at it. But if I had to, you know, pick one thing that he was super passionate about, it was the research. And he ran a big research lab and just like loved research. So
Loves the scientific method.
yeah,
Big,
exactly.
big fan of that.
Yeah, yeah. And so I really enjoyed my PhD years. I liked learning new things, but I also there's a lot of frustration in it. It's a much different pace than medical school and residency. Because you can start an experiment and then your cell lines die or your mice don't breed or something, and you're back to square one, and you're like, did I just waste 3 months? And sometimes you feel like that. Sometimes you look at the silver lining and say, well, I learned something, even though it didn't work the way I wanted it to. But so I one thing I learned from doing the PhD is that I didn't love it enough to have it be my career.
Mhm.
And whereas other people do, and that's it's what I needed. I learned through all this training that my passion lay more with patient care and
Mhm.
being able to uh, see patients and do an intervention. And that's why I think I was drawn to to a surgical specialty where you can do something to make a difference, and in a shorter time frame. And just seeing my dad and how even though he loved research and loves research, he would it was still a challenging career. I'd see him be work long weekends into the night, like when a research funding grant was due, and they were working on getting papers published and things like that. And so I saw him working hard at it, and I realized that uh, you know it, it's very competitive, and to do well you have to have a lot of passion for it. And I, even though I found it interesting and enjoyed it overall, I didn't see that passion in myself
Mhm.
for the research. And so I think he recognized that in me too. And while there's probably some unspoken pressure, just you kind of want to, if you respect your dad, you kind of are drawn towards some of the things that they like.
Sure.
And I'd be dishonest if I said that he didn't have any influence in me going into medicine, but he's always been really, again, he wants me to do what'll make me happy. And I think I think even though he wasn't, didn't become a surgeon, wasn't, that wasn't his passion. I think I could tell he always really respected surgeons, and thought it was really neat. And so he was always like interested in hearing what I was doing, and he's really good at kind of cheering me on in, the path that I've taken.
That's awesome. Good to have a supportive dad. So another great mentor in your life
Yeah.
to lead you down the right road. I'm curious though with the PhD program. One, just the curiosity of why they send you into medical school for 2 years, let you have a little sabbatical, send you off to a PhD, and then bring it back into medical school. That I don't know. I feel like you're after that PhD program, you're gonna have a bunch of people like, well, I got my PhD. I'll just stop. I don't feel like going back to medical school for
Great.
a few years. But that's not my question. My question is more when you went into the PhD program, what attracted you into the genetics of hearing loss specifically? Was there an event in the past? Did you have a friend that experienced that? What was that drive that got you into
Um,
that?
uh, so honestly, I don't. Some people have like a personal or family member health issue that kind of
Mm-hmm.
draws them towards one field. I was looking for a good mentor, uh, and I rotated with a guy who does cancer research, and he was great. I had a good experience in his lab one summer. And so I kind of had a short list of people whose labs were kind of accepting PhD students, um, and who were, had a good reputations as mentors. And I rotated through a couple labs, and you talk to them about the potential projects that you'd be working on there. And I had some good options, and ultimately I liked the ideas that Dr. Smith had about. I liked the idea of working on some gene therapy type stuff that seemed pretty cutting edge. And I liked the fact that Dr. Smith was both that he was a physician, and saw patients as well as doing science, which was kind of the path that I that I was on at the time. And so it just fit well. And I and kind of as you get into doing more research, you start to love that thing more, as you learn more about it. And so, and even though if you'd asked me a couple years before I started, are you going to do ear stuff? I probably would have been like, maybe, that would be interesting, but I don't have a particular interest in it. But as I got into it and learned more, and it really, kind of my interest in it grew.
Yeah, that is, I mean, it's just, especially the genetics behind it, right? I think there's everybody wants to know about their genetics, and if something goes wrong, hey, what's wrong with me? Those types of things.
Yeah.
For whatever is ailing you in your body, you always want to know. And so genetics, I think, is just interesting no matter what.
Yeah.
Hearing loss, which impacts, and correct me if I'm wrong, a small percentage of people.
Yeah. Yeah, I'd say overall, genetic hearing loss is a small percentage. If you think about, people who, as we get older, I think like 80% of
Yeah.
80-year-olds probably should be wearing hearing aids.
Yep.
So in that respect, it affects a lot of people. But you're right, it's not, it's fairly rare for, a kid to be born deaf, although we do, of course, see that.
Yeah. So talk to me about some of that technology, because this was one of the questions I definitely wanted to ask you is, you see those videos on Facebook, on YouTube that just tug at your heartstrings, right? There, which ones I'm going to talk about, where it's like a young deaf person gets that hearing aid, or that
Cochlear implant.
Cochlear. I was trying, cochlear implant for the first time, and they hear their mom's voice,
Yeah.
and they lose it. Tell me about the technology that goes behind that. How does that work from an implant standpoint?
Yeah, so that's pretty, it's incredible. Yeah, and those videos are heartwarming and amazing. So it's a cochlear implant. So hearing aid, just you wear it. People are familiar with it. You wear it in your ear, and it amplifies sound, and they can tune it to and personalize it, and do some things with it that way. But it's just amplifying sound. The cochlear implant is for people who don't have much useful hearing at all. Who you'd put a hearing aid on them, and they still wouldn't get anything, any significant benefit from it, because their hearing is so far gone. And what it does, it's a surgically implanted electrode into the cochlea. The cochlea is a snail-shaped structure in the inner ear, and to approach it, you drill through the mastoid bone, which is that bone behind your ear, and you expose the cochlea, and then you push the electrode of the cochlear implant into the cochlea, and then it stimulates the cochlear nerve, and to send sound to the brain, and it's not, the quality of sound is a little bit different than natural hearing, and there's definitely a learning curve, especially for adults who get it. But it's truly amazing, and that they have this technology, and children are implanted. We implant kids less than 1 year old, and they can learn speech, and development is wonderful. And we're also now implanting more and more older people who've lost hearing as they've gotten older, from noise exposure, or just the aging process, etc.
When did this type of technology come out?
Oh, I think it was in the early 1980s. And it's gotten a lot better since then. I know that a lot of the some of the early work was done at University of Iowa, and they continue to innovate with cochlear. They've got a really strong ear program there, and they continue to innovate with cochlear implants, and improving the technique and the devices. And so it's I'd say, yeah, at least 40 years.
Oh, wow. So let's look 40 years into the future, when you and I are old and gray. but you'll still probably be just as handsome. But what do you think the technology? What's kind of, I don't want to say cutting edge, but like what are some of the talks? What are some things that are coming out? The cochlear implant was, let's say 40, 30 years ago, really started to ramp up. What's the next thing?
Yeah. I think it will be I think it will be with so the genetic side of things and gene therapy.
Sure.
Uh, and so delivering genes or correcting abnormal genes that cause hearing loss. One of the, I mean, if we could so inside the cochlea are these sensory cells. They're called hair cells because they've got these little cilia on top that kind of look like hairs under the microscope. So they're called hair cells, and they're the cells that sense the signal and pass that on to the nerve. And with hearing loss, those usually degenerate, and we can't regrow them. And there's some birds apparently can regrow them. Mammals don't have that ability. And so if we could cause regrowth or implantation of these sensory cells and have them connect correctly, that would you could theoretically restore natural hearing to people who've lost it. And I don't see that in the next 5 to 10 years, but when you think about how far technology has come and how much more we're learning, and people are working on this, and I think it's possible, and I think it'll happen someday.
That's amazing. Yeah, this my next question then probably isn't one that you've been asked before, just because I don't know, I just thought of it and it's kind of way off the wall. But you know how they can do a lot of genetic testing in utero for different abnormalities and Down syndrome and things like that. Okay, two-part question. One, is there testing now where we can determine in utero if a baby has hearing loss or vision loss? That's part one of the question. Part two is, do you see at some point in the future that we could have that genetic testing and then correct prior to birth?
Yeah. That's yeah, I mean, the answers are yes. As far as testing now, so one of the things, it wasn't my project in the lab, but another student in our lab, his name's Elliot Shearer. He worked on a genetic test to there are hundreds of genes involved in the hearing process, and so anything that goes wrong in any of those genes can cause hearing loss. And so there's hundreds of different genes that to test for when you're trying, if someone is born with hearing loss. There's a lot of options. There's some that are definitely more common than others, but there's a lot of options. And so and we're still trying to find what these genes and these mutations are, but there's a lot that are known. And Dr. Smith's lab and other labs have identified a lot of them. And so my friend Elliot and under Dr. Smith's help or instruction, came up with a genetic test for all of the known genes that can cause hearing loss. And so it's called the otoscope, and you get a blood sample from the patient and you run it against this panel of genes to see which mutations, and about 50% of the time they can find the genetic cause of the hearing loss. About 50% of the time they can't. But those tests, and more tests have come out since then, and they're getting better and better as we learn more and more. So yes, there's testing, and I don't see that so much in the kind of prenatal period, embryonic period, although theoretically, I mean, you could screen parents, right, and see if parents have any of those mutations that then could potentially be passed to the kids. And theoretically, you could do embryonic testing to see as well, if you thought that would be helpful. The one application, one reason to know, you might say, well, why do we want to know what mutation it is? Just, you know, if we're
It
getting,
is what it is.
it
Yeah.
is what it is. We put a hearing aid
Mhm.
on the kid or cochlear implant or, you know, but there, some of these are syndromic, meaning that it's not just the ears that are affected. There's other body systems that are affected by these genes, and the
Okay.
hearing may be the first manifestation. And but there might be genes that also affect the heart or the kidneys or the eyes. And so if you identify a mutation in a kid that is a syndromic type of deafness, you might then oh, we need to send this kid to the ophthalmologist to have his eyes checked also, or oh, we need to get this kid an EKG or or get their kidneys tested, so, for other things that could potentially go wrong. So there's been a lot of advancement in that area, and that's done a lot of good. As far as changing things, I know a previous podcast you listened to talked about the CRISPR technology, where they can, go in and actually change genetic material. I think we're just on the front end of that, and that's gonna, change things. So I think we're gonna see big changes. I don't know the time frame, but I think there's a lot that's gonna be done.
Yeah, I mean, that's one of my fascinations, and something that it always seems to come up during these podcast episodes, right? Is medical technology, and it's just something that I'm always curious about and fascinated with some of the things that, you know, physicians and researchers that are out there that just take a simple idea and then just turn it into a big thing that can be impactful for so many people. So I mean, yeah, if that is down the road where they can figure out and say, hey, this genetic abnormality is going to cause hearing loss, and we can, or hearing loss, not ear loss, but hearing loss in utero, we can correct that. Maybe that change in that genetic code then can, maybe to your point, there was other heart issues or kidney issues that would have followed eventually,
Right.
and you've just rapidly changed that person's life by
Yeah.
catching that early. So very cool. Well, speaking of genetic uh, non-commonalities, if that's a word, I think I just made it up. You are a dad of twins.
Yeah.
Tell me a little bit about that. As you're, I think you said you're visiting up, you're finishing up residency, or was it in your
Yeah.
fellowship? I can't remember which, but you and Aaron had twins. Tell me about that.
Yeah. Yeah. So they were actually born in my fourth year of medical school, or I'm sorry,
Mhm.
of residency,
Of
fourth year
residency.
ENT residency. And I believe I was on a pediatric rotation also when they were born. And my goal, because twins often come early and sometimes, it's just a little bit more complicated sometimes. And my goal was not to have to round on my own kids. Uh,
Yeah.
part of the pediatric ENT team, but we were very fortunate they're both healthy. It took us 4 rounds of IVF to get pregnant. And that's a big thing. More, for my wife, but also, it's as a husband trying to support and help, and it's a challenge. So we're super, super, super grateful when they finally came. They came at 36 weeks, so she did, great job. Like, 4 weeks, only 4 weeks early, which for twins was great. And
Hmm.
uh, um, the my daughter got to go straight to the newborn nursery. My son spent one night in the NICU just with a little respiratory support, and then the next morning he got to go to the regular newborn nursery, and both are healthy. And the I will tell you, the first 6 to 12 months of their life was just, I mean, it's a blur. Like, it's
Chaos.
survival mode, because I'm in residency, so it's like, early morning, probably, often like 6 a.m. getting to work, and often not coming home till 6 or 7. And my wife she was in a job that was, had a little, just less, her hours were better. And so that was, but I just remember during that time, like, every I feel like all I did was come home, like go to work, come home, and like wash bottles and so, like just wash all the bottles and I remember we tried for a time we tried to figure out what was the best way because my wife was home with them during the day and she'd be exhausted from two babies and uh and so I'd come home and I'd take like the shift and from like 6 p.m. to midnight. I'd be there with the babies while she tried to sleep, and then I needed to get to sleep so I could wake up the next morning. So then I'd go to sleep, and she would take them overnight. That worked okay, but we eventually went to just I would be in charge of my son because he liked the bottle better anyway, and she would be
Yep.
in charge of my daughter because my daughter would nurse a little bit more and uh and just whichever baby cried that parent would go get them and I remember like I just have this picture in my mind of like being super 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 exhausted like on the couch with my son like half asleep with giving him a bottle, but also like in as exhausted and hard as that was, it's like a really good memory. Like it
Hmm.
was bonding time with my son and it's one of those things kind of like medical training where you look back at and you're like, man, that was hard. Somehow, in some ways I don't know how I got through
But you
it, but
made it.
you made it and there's some sweet memories in there at the same time.
It's the tale as old as time when you have multiple kids. I mean, you had two kids at one time. I had two. I spread them out, you
Yeah.
know, a few years instead of a few minutes. But tale is old. Once you have multiple kids, it starts out as zone defense, right? You were a
Right.
basketball player.
Yeah.
Starts out
Yeah.
as zone defense, and eventually it goes man to man. You got to figure out you got to
Yeah.
figure out that man to man defense and who's going to take what. Uh,
Yeah.
I all my friends that have multiple kids have the same story you do.
Great.
My younger sister, I don't know if I had shared this with you before, but my younger sister has twins. Just had them
Awesome.
in February, so
Okay.
they're coming up on what 10 months old now.
Yeah.
So when you said that first 6 to 12 months is chaos,
Yeah.
uh, they're fun though. My nephews they're always smiley. You can tell just their interactions with each other, I think, is what's really cool. And I'm sure your son and
Yeah.
daughter had the same thing,
Yeah.
but
Yeah.
it's wild.
Yeah. It's so fun to see. And um, yeah, my dad, I feel like whenever he would come over and like even, when they're older, he's like, wow, there's two of them. It's amazing. And but as they get older, it's fun because they're in some ways it's maybe a little bit easier because they've got built-in playmates, and so
Sure.
there's that benefit as they get a little bit older.
Yeah, and then you became a more rare statistic of people who have twins. You threw a third kid in there.
Yeah,
You decided to have a third
yeah,
and pile
that's
on to
right.
add another playmate.
Yeah,
I believe another daughter.
yeah, daughter. So the twins are 8 now, and my our youngest, the daughter is 5, and yeah, and she's awesome, and that was during my that was right. She was born in May of 2018, right before I finished up my fellowship, and right before we moved. So she was born in Iowa City, and then a couple months later, we moved to Quincy and started our jobs.
Gotcha. Yeah, my youngest son was December of 2014 or
Okay.
2018. So
Yeah.
right around the same time. That's about when I was switching careers too. So look at us. We're just
Yeah,
making chaotic decisions
that's right.
with newborns. Oh man. So tell me a little bit about career changes and things like that. You and Aaron deciding to go to Quincy, going to this I called it a multi-specialty
Yeah.
practice. I don't know if that's the right phrasing, but
Yeah.
uh juggling careers. Your wife an oral surgeon, you an ENT surgeon. Tell me about kind of the medical household that you've created, right? How does that work? And I'm going to go deep here just because I thought of it and I want to go deep. What does that do for your marriage? I know you said you're at a conference to become a better dad, but as you're having twins, as you're going through I'll take the kids from 6 to midnight, and then, you're back at it after you've just had them all day. You're hardly seeing each other. let's also switch careers and move to, Western Illinois. What does that do for your marriage in that situation, being both medical professionals?
Yeah, I think there's like a lot of things. There's pros and cons.
Mhm.
I talked about, in kind of changing my course from being academic medicine to deciding ultimately to do private practice. And honestly, like if my wife did not have a career in medicine, I would probably be, an academic doctor at some university.
Sure.
And but because what I realized, as we kind of were going through it, like she's passionate, she loves what she does, and uh, and we needed to find a way to, so we both, enjoy, like, career is important to us. We, maybe even her more than me feels kind of called to what she's doing in a career sense. But we also, family is important, number one for us. And so we need to find a way to do that. And that's when I realized that probably the private practice would be the best opportunity to make that happen. And
Gives you the flexibility and
it gives us the
yeah.
flexibility. Yeah.
Mhm.
And so we joined this multi-specialty group in Quincy, Illinois. That's got about 100 physicians of all different specialties. I've got one partner right now in our ears, nose, throat department. We're probably going to add another one soon. And she's got a partner in oral surgery. They actually they did not have any oral surgeons in the clinic when we were looking for jobs, and it had been hard to find jobs, for both of us in the same spot. And when Quincy called, I said, I'm only going to come look if you tell me there's a job for an oral surgeon. And they got back to me in a couple of days and said, there's a need. We'd love to talk about, bringing your wife on. And they brought her and another oral surgeon in the community joined at the same time. So we are, she works 3 days a week. And I work 5 days a week, but I've kind of, I schedule my hours. So I go in, I usually start seeing patients at 7 a.m. and I try to see my last patient by 3 p.m., maybe 3:30.
Yeah.
And then, finish up some notes. The goal is to be home, around 4 o'clock. Often it's, doesn't always happen that way.
Yep.
But that's the goal because Erin goes to work a little bit later, 8:30, and stays a little bit later on the 3 days that she works, and then she's home 2 days. So we have childcare on the 3 days that she's working, but I try on every day I try to be there kind of late afternoon. I take the kids to their gymnastics class at 4 p.m. and their dance classes and things like that. So we try to so I think private practice has given us the flexibility to juggle our schedules a bit and try to make it work that way. As far as what it's done for our marriage, I think there's a lot of benefit that we understand each other. If I'm caught up late at work, she kind of knows that that's not really because I want to be
She
doing
gets
that.
it.
Because
Yep.
something, she gets it. So, something came up and you got to take care of the patient. And likewise for me about her, where our specialties are kind of focused on the same area. There's definitely some overlap there. A couple of weeks ago, I was on call and it was a dental abscess, and she came in and did that, and I peeked into the operating room just to say hi and see
There.
how
Give her a pat on the back, say, hey,
see
you're doing a
how
good job, honey.
yeah see how the professional tooth abscess trainer does it.
Nice.
Learn a thing or two from my wife.
Mhm.
And but also there's I think just the training and the demands of the job have I'd say that our marriage is really good and has been really good, but definitely, like most marriages, I think, kind of have its ups and downs. And and to really make a marriage work, it's challenging. It's not like if you fall into old habits and aren't, putting forth effort, things can slump down, and I've seen that in our marriage, and we've been one thing that we've been trying to do better at this past year or two is going on regular dates. We try to go on a date on every Saturday evening. Doesn't always happen, but when you try, at least it happens more than if you don't try. And and then just having conversations with each other, and just trying to be unified in that regard. So I think
I think the biggest pillar there is understanding each other, right? If you were doing your ENT private practice and she was a librarian, right, or something like that, where it's like, hey, you're in at 7, you're out at 3. There's no exceptions to that. And so when you're late, that can obviously cause some issues. I just think once you get into the trenches of fatherhood, and I think you would agree with this, like, you just have to have an understanding with each other. Like, nothing's easier anymore. Like, there's no skating by. I do like the date night thing. My wife and I've been trying to get into that as well. Now that our kids are older, and calling on a babysitter is not as difficult when you're like, hey, will you come watch my 3 kids who are 5, 3, and 1? That's really hard. But when you get 9, 7, and 5, it's that high school babysitter is a lot more apt to say, I'll come over and hang out with your kids for a couple hours. And I just think that's really important. We again do our best. We don't do a good job of scheduling it, but we take advantage of it when we have that opportunity. And I think that's really important, to get some time away. The thing you and your wife have to worry about then is, do you sit there and talk about cases when you're when you're out to dinner? You got to keep work out of it.
One interesting observation on that, like, and it's probably true of most careers, like, you kind of you go home from work, you get home from work, and you kind of want to decompress and like talk about the stresses of the day. And we observed recently that we found that a lot of the things that we like come home and are talking about is kind of like venting, like, oh man, I had this difficult patient that wasn't listening to what I said, or just stuff like that. And we were talking recently that we should be careful what we say, because I think there's some value in venting, but there's also, like, we like our jobs and we like our patients, and we're really fortunate to have these careers, and we want our kids not to, like, they hear things, and you
got 3 sets of curious ears that want to know everything.
We want them to know that really we like our jobs, and and we want them to kind of have positive feelings that way. So, and there's my brother's he's in his last year of anesthesia residency. So, and then there's my dad, and and my wife, and so we've got kind of like medical people in the family. And when we're all gathered at my parents' house, often conversation will turn to medical stuff, and then there's like
one-offs.
Then there's my 98-year-old grandma. She's like, no, I don't want to hear any of that stuff.
Oh man. I'm finding that more and more, especially with the ears. You got to be careful what you say in front of your kids. I'm finding it out just in the sense of driving. I don't want to say I have road rage, but I'm certainly not afraid if somebody light turns green and they're sitting there looking at their phone, I'll tap the horn and say a few choice words. I think we all do it. But now my 9-year-old will be in the back seat, and she'll be like, oh my God, come on, get going. What's this? Why isn't this person moving? It's like, oh my gosh, I got to get a little bit better about that behavior. So if you find some tips at the conference that you're at there in Austin, do share, please. Cause I got to get better at that. One thing I want to wrap up with you. I know we've talked, ENT is your specialty. Got to talk about life, but we haven't talked about the N and the T, the nose and the throat. And I think one thing that I know about you that you are passionate about, probably something, I don't think I have it, but something that you're passionate about is sleep apnea,
Yeah.
and being able to treat obstructive sleep apnea, which to me sounds like a fancy way to say snoring.
Yeah.
Uh,
Yeah.
am I right?
You are, you're right. You're partially right.
Yeah.
Um,
So I get nudged every night, 2 or 3 times because I'm snoring, and then if I lay on my side, that usually fixes it. But
yeah.
tell me a little bit about what goes into sleep apnea, because again, this is just curiosity. I don't know.
Yeah.
And then two-part question then is, what can people do on their own to try and correct that?
Mhm.
And then what are you currently focused on, within your world in a surgery point of view? What are you focused on with obstructive sleep apnea that can really change people's lives?
Yeah. Good question. So the so snoring, and so there's the big blanket term is sleep disordered breathing,
Okay.
and snoring would be on the one end of the spectrum, the very mild end of that, and then on the others, and then you get into, as it gets more severe, you get into obstructive sleep apnea, mild, moderate, severe. And snoring, while being annoying to, whoever's around, isn't necessarily detrimental to your health, but when that obstruction becomes worse to where you're actually having pauses in your breathing, CO2 rising in your body, oxygen dropping in your body, that can over time take its toll. And also just the lack of good quality sleep, is what obstructive sleep apnea is something, it's usually talked about as a multi-level disease, meaning that anywhere in the upper airway, the nose, the tongue, soft palate, uh, that's that's collapsing when you're asleep. And when we're asleep, we're often, on our backs, or, where gravity takes its toll. And then when we're
Mm.
asleep, the muscles relax. And so it's easy for things to collapse and block our breathing. And then we're trying to take a breath in, but we're not getting a full breath. And so our oxygen is dropping, CO2 is rising, and our brain is fortunately smart enough to realize that and wake us up so we can, get that muscle tone back and get a good breath in, to normalize things again. But when you're doing that every 1, 2, 3 minutes, you're never, it's not like it's waking you up like full that you're awake, but it's bringing you out of a deep sleep. And so when that's happening every few minutes or less, you're never going to be able to get into that deep restful sleep that's so important for our minds and our bodies. And we're realizing more and more the value of good sleep,
Mm-hmm.
to general health and longevity. Uh, and so with sleep apnea is super common. It's definitely more common in people as our weight increases. If you get heavier, your likelihood of sleep apnea goes up. But it's not a perfect correlation. There's a lot of slender people without much weight to lose who have severe sleep apnea. And so it's something that people should be aware of. And if you are snoring loudly, if you're having poor, just waking up in the morning feeling like you didn't, not rested well, sometimes morning headaches, those are some of the symptoms of obstructive sleep apnea. And that'd be something to talk to your primary care doctor about. There's in-lab sleep tests where you go and they hook you up to monitors and in a sleep lab, and they can get a lot of great data that way. But there's also home sleep tests that they can set you up with. You take it home and you do it in your own bed, and to tell whether or not you have sleep apnea.
Yeah, I mean, if I'm not sleeping good in my own bed, how am I going to fall asleep in a lab?
Yeah,
There's no way I'm falling asleep.
right. Yeah, there's pros and cons to each, because they can gather more data in the sleep lab, but it's not your natural environment also. And so
Mm-hmm.
there's I think there's a lot of people appreciate having the option to do it at home.
Mm-hmm.
So traditional, when if someone's diagnosed with sleep apnea, the standard of uh, kind of the gold standard treatment is CPAP.
Hmm.
continuous positive pressure. This, you can wear a mask that just goes over the nose, a nasal pillow, or over the nose and mouth to push air, and kind of it helps stent the airway open, so so you're not having that obstruction. The problem is a lot of people don't get along with their CPAP. It's
Yep.
as you can imagine, people feel claustrophobic. They knock it off at night. They just hard to fall asleep with something on their face. They just don't want to use it, and so if you're not using it, then you're not getting any benefit from it.
Hmm.
And so every once in a while, I'll meet a patient with sleep apnea. They tell me how much they love their CPAP. They don't leave home without it. It helps them get a good night's sleep. And for those patients, like that's great. That's they're model patients, and that's wonderful. But I see so many patients who come in and they're like, yeah, I'm supposed to be on a CPAP, but I just can't tolerate it.
Hmm.
And I need, what are my other options? For mild sleep apnea, there's things like where an oral appliance that a dentist can make that kind of pulls the jaw forward. You put it on at night, it kind of pulls the jaw forward, pulls the tongue forward with that. There's some, looking at the nasal airway to, to help just if you open the nasal airway, you can convert people potentially from being mouth breathers to nose breathers. It's really, you can try it
Hmm.
sometimes. It's really hard to snore with your mouth closed. You may have heard about like mouth tape, that you don't
Hmm.
want to do that if you can't breathe through your nose. But if you have a good nasal airway, keeping the mouth closed and getting most of your air through your nose can really help a lot of people. And then there's positional things. Your sleep apnea tends to be worse when you're on your back. So if we can encourage someone to lie on their side, traditional way of that is like sewing a tennis ball on the back of a shirt and just wearing that, and that encourages you to be on your slide. Or they make
Hmm.
wedges, or there's newer, fancier devices that'll like vibrate if it senses you're snoring, causing you to roll over and stuff. So there's a lot of stuff coming out technology wise with this. Now, when we think about surgery, I'm usually thinking more about people with moderate to severe sleep apnea. And traditional sleep apnea surgery was manipulating the tissue of the airway, and surgery on the soft palate or the tonsils or the back of the tongue, and trying to alter that anatomy. There's you can. My wife knows more about this than me, but breaking the jaw and pulling it forward. Uh,
Yep.
the and the problem with a lot of the sleep surgeries is that they are only addressing one level. They're either addressing the tongue or addressing the soft palate. And a lot of, as I mentioned, a lot of sleep apnea, most sleep apnea in adults is multi-level. And the big game changer in sleep surgery came out about 9 years ago. It's called the Inspire. It inspires the company Inspire implant. It's a hypoglossal nerve stimulator. The hypoglossal nerve is a nerve that controls the movement of the tongue. And so this is an implanted device that is, I describe it as a pacemaker for the tongue. And so
Okay.
it sits, there's a processor that sits in the top of the chest under the skin. And then there's an electrode that sits between two ribs, between the intercostal muscles, to sense when you're breathing in and when you're breathing out. There's another electrode that sits under the chin around the hypoglossal nerve. And so when the patient turns it on at night, when it senses that they're getting ready to take a breath in, it stimulates the nerve to move their tongue forward. And we can control how strong that stimulus is and how much the tongue moves forward. And that relieves the apnea, and it brings the tongue forward. It also tenses up the soft palate. So it addresses multiple levels at once, and it's been highly effective. And it's a super, super cool thing. And so that's when people ask me about kind of what my favorite surgery is, or I love doing ear tubes in kids, and because that can make a big difference in a kid's
Hmm.
life. And I love doing the Inspire implant because that can also make a big difference in people's lives. We started doing it in 2020 in Quincy, and tens of thousands of people have been implanted worldwide.
Hmm.
We're somewhere above 50 in Quincy now in the last few years, and I work closely with the sleep medicine doctor there, and we're getting great results for the patients, and so that's a cool thing.
That is fantastic. That's got to be impactful because you're probably implanting this, and then you come back and talk to that patient 6 months later, and they're like, "Man, let's say they're 55 years old, and they're like, I haven't had a good night's sleep in 30 years until this thing was
Yeah,
implanted, and it completely changes their mood and their health and their just general disposition. I'm sure
yeah,
being able to get that good sleep.
yeah. It's super fun to hear. I was at just out and about once, and this guy's wife came up to me and was like, "You probably don't remember me, but you did the implant on my husband, and he's not even snoring anymore, and it's just, things are so much better." So it's fun to hear those stories.
That's awesome. How much of the treatment is, or is any of the treatment? I should ask it this way, where you're talking with the patient and saying, hey, let's say they are a bigger person, they've gained some weight
Yeah,
over time, to where it's like, okay, on top of this, we probably need to address health, in the sense of nutrition and
yeah,
making sure that we are losing some pounds. Like, this is going to work for you. It will work better if we lose 15-20 pounds to
yeah.
really, not exacerbate
Yeah,
the implant.
you're right on with that. That's a big part.
Mm-hmm.
If someone's overweight and they have sleep apnea, you got to talk to them about weight loss. And I'm fortunate enough that our sleep medicine doctor in Quincy is also has a specialty in obesity medicine, and so we work like really closely together. I can send him patients for sleep studies, and he can send me patients who aren't tolerating their CPAP. And if somebody needs weight loss, I can, encourage them to go see him for weight loss. And you're exactly right about it working not as it works better if we can get some weight down. And there's depending on your insurance, to get to qualify for the implant, you need a BMI of either under 32 or under 35. That's they've been gradually pushing that upward, but it definitely works better if you're less. And I had one patient who was an example of that, she was under BMI of 35. She qualified for an implant. We implanted her. She was doing great. I saw her like a year later. She came in. She's like, "It's not working. Like, I'm not getting good night's sleep anymore." She had, I can't remember for sure. I think it was like an endocrine disorder where she gained a bunch of weight. You know,
Mm,
and so she was a lot heavier than she'd been, and uh, that was the reason why. And I just pointed that out to her, and I said, we can get this working again, but we're gonna have to get some of this weight off.
for sure. How do they? I would imagine they handle that okay. They probably can self-identify that, yeah, I've put on some weight, and
Yeah,
it just takes a little effort. But I think hearing it from a professional like you would, just from a health standpoint, if you just strictly lean on the, hey, this device is going to work fantastically under 35 BMI, you can kind of
right.
roundabout say, hey, we gotta get some fitness back into
Yeah,
our life.
yeah. No, those are, there's so many things in medicine that we try to do. And people talk about supplements and all these fancy stuff, high tech stuff, but really, like, the basics are, I mean, they're there for getting good sleep, getting good nutrition, getting some exercise, not smoking. If
Mhm.
you check those things off the list, you're doing pretty well.
Absolutely. I have one more question for you before I let you go out and enjoy Austin, Texas.
Uh, is it about your tubes?
No, it is not. We're not going to bring up that trauma. That's
Can I tell you one thing before your last
yeah.
question? And
Yep.
I'm curious to see if this is going to make you feel bad or not. We don't make kids wear earplugs anymore when they have ear tubes.
What? Oh my gosh.
They are our academy. They came out with updated guidelines when I was in residency, so it's probably like 7-8 years ago, and they said no more do we need to require all kids to wear with tubes to wear earplugs.
Unbelievable.
They
Yeah.
just didn't
I
find great evidence for it. So
oh
that's
man.
yeah.
I had I had two, I believe. I'll my mom will watch this episode and she'll probably correct me, but I'm pretty sure I got them in and then extracted. and then like a year or two later got him in again in the
Yeah.
ventricular extract. And I only wanted to ask you about it just because my son, who's about to turn 5, hearing is not great. Maybe his hearing's fine and his listening sucks. I don't know, because I know hearing and listening are two different things. But I don't think his hearing's great, and we're going to take him to an ENT specialist to check that out. But apparently, one of the kids in his class last week came to school. He had missed school for a couple days, came back to school and said he got tubes in his ears. And so my son is like, he's in preschool. He's like, what are tubes? What does this mean? And I had to explain it to him. I equated it to like Super Mario Brothers, the green tube. It's kind of like that. You have
Oh
to have,
yeah, I like that.
you kind of,
Yeah.
yeah, you kind of have to have some flow. And so he got it. And then he asked me, he's
Yeah.
like, after I told him I had it twice, he's like, oh man, do I have to get tubes? I'm like, gosh, maybe. I don't know. But
It would
we'll find out.
be
But
not out of the question, but it would be more rare for a kid over 5 to need tubes for the first time. Usually it's younger kids. But yeah, hopefully he won't. But if he does,
hopefully not.
he won't have to wear earplugs at the pool.
Yeah. Well, I'm sure technology is a lot better than it was in 1992. So you bet. My last question was, just because we are both a fan of this team, it's a hard question. What are the Iowa Hawkeyes going to look like next year in football?
Oh man. They've been fun to watch this year. Aside from that Michigan shutout.
Yeah. I think we have two different definitions of fun.
Oh, yeah. No, yeah. I mean,
their special teams is fun to watch.
Yeah. I think overall they did better this year than I expected them to.
For sure.
So in that regard, it's been a good season. But yeah, I hope we can get some more offense going next year.
Yeah. I mean, with Brian Ferentz heading out, I mean, they haven't said who they're going to bring in. Obviously, they'll wait until after the bowl game against Tennessee. But
yeah,
I mean, I would love for it to be like a spread offense, fast pace. You know, what's his name? Cade McNamara is going to be back, so
yeah,
if we can get things rolling, it could get really exciting at Kinnick. But
yeah, it could be really good. Right now, well, I guess we have the bowl game on January 1st, right? Citrus Bowl. Yeah, and then I'm excited about women's basketball this year with Caitlin Clark. I'd love to. I don't know if I'm going to be able to, but I'd like to get some tickets to a game this year.
It's hard to do. I've looked it up a couple times. I've watched more, Hawkeye basketball, women's basketball than I ever have in my entire life. Obviously because of Caitlin Clark, and then my oldest daughter plays basketball and she just loves watching her. So, but yeah, I've looked up tickets to a few games against like teams that I did not think were going to be, popular to go to, and you go look up tickets, against Southwest Missouri State or something like that, and tickets are sold out. And I'm like, are you kidding me? Like,
yeah, it's great. It's amazing what she's done for college basketball and women's sports. Yeah, really, really fun.
Yeah. I just don't know if she goes to the WNBA, because she's probably making more money now at the University of Iowa than she would if she goes to the WNBA. So
yeah, that'll be interesting because she's a senior, right? But it's
correct.
She's got one more year potentially because of the COVID year.
Correct. Yep.
Yeah, that'll be interesting to see.
We'll see what happens, but we got some exciting times to be a Hawkeye. So
yeah, for sure.
Awesome. Well, it has been a pleasure, Abe. I'm glad we got together to do this. I'm glad you took some time out of your day to sit down and meet with me. But I want you to go out and enjoy Austin, Texas. Learn how to be a fantastic dad. You probably are a fantastic dad already. You're just honing in those skills, or maybe you're teaching others. But I look forward to bumping into you at some point in the future.
Yeah, awesome. Thank you so much, Nate.
Absolutely. Be well.
All right. Bye-bye.